Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, SSR, for the kind invitation. We can start. Okay, they say that there are no two cases in lupus that look alike. And here I'd like to share with you one of my patients who presented with a kind of rare initial manifestation. Okay. All right. So the patient was 22 years old, female, when she presented complaining of joint pain with the generalized malaise, dry cough, shortness of breath, and she had diffuse abdominal pain. And she had a bilateral lower limb edema of 2 weeks duration. In her past medical history, there was a recent diagnosis of iron deficiency anemia that was 3 weeks prior to presentation when she had received 1 unit of packed RBCs. She denied any illicit drug use, and she has recent febrile illness. There was no blood loss from externally, and she works in a juice shop. With the previous admission, she had admission to another facility that where the iron deficiency anemia was diagnosed, and she was transfused with 1 unit packed cells. The lab tests were positive for a hemoglobin of 7. She had very high ESR, 140. Her ANA was 1/2560, and she had low C3, C4. She was negative for DNA, and her rheumatoid factor was negative as well. Now a TTE was done, and that revealed pericardial effusion, and she had cardiomyopathy with severe reduction in the ejection fraction for like 15%. Upon physical examination, she was having no fever. Her blood pressure was 120/90. Her heart rate was 115. And she maintained saturation of 98% on room air. She had facial rash. The chest X-ray revealed the lower zone crepitations, and the abdomen was mildly tender with bilateral lower limb edema. Her ECG was showing sinus tachycardia with diffuse T-wave inversion. So we entertained the diagnosis of systemic lupus erythematosus with initial presentation as cardiomyopathy and heart failure with suspected lupus nephritis. We referred her to emergency room for admission, and we considered IV pulse steroid and to complete her investigations. While she was in the inpatient unit, she became oliguric. Her chest X-ray revealed blunting of both costophrenic angles, and the abdominal ultrasound revealed hepatomegaly with small abdominal free fluid. We repeated her TTE that showed 15% ejection fraction. She had dilated dimensions in all chambers, heart chambers, with global hypokinesia, with the severe functional tricuspid regurg and mitral regurg, impaired right side function with pulmonary artery pressure of 40 with moderate pericardial effusion. Later on, her blood test showed hemoglobin 10, and she had normal MCV. Her creatinine was 2.2 with coagulation profile that was INR 1.4, PTT 26, and high D-dimer. We made sure there was no thrombosis. Cardiac markers revealed a trop T of 193, pro-BNP was 38,650, and the endocrine panel revealed high PTH, calcium 8.2, with the TSH elevated with normal free T3, T4. Now the urine exam showed 2+ protein and 2+ blood. She had white blood cells 6 to 10 with the UPCR of 1.27 milligram per deciliter. Now the CRP was 1.3 and her ESR was 50. Her vitamin D was very low. With the rheumatology panel, she had ANA positive. DNA showed positive this time with a low complement C3, C4. Antiphospholipid was negative, ANCA negative. ENA, she had negative Joe SCL70, U1 RNP, and the virology tests were all negative. Quantiferon test was indeterminate. So we had the cardiology on board, and they had suggested to start anti-failure treatment like ARVs, beta blocker, furosemide IV, and we decided to do a cardiac MR. The nephrology team was also on board, and they had advice to go for furosemide. Patient was very overloaded, infusion, and we withheld all nephrotoxic medication, and we scheduled her for kidney biopsy. The first week on the hospital, we started a pulsosteroid as 1 gram for 5 days. The kidney biopsy was performed, and she was kept on infusion, furosemide, after which she was back to her euvolemic state and maintained good urine output. And the second week, she was relatively stable. She had she developed irregular pulse, when cardiac arrhythmia was confirmed. She had premature ventricular contracture with the non-sustained VT, and that was probably attributed to her electrolyte disturbance. She was transferred to ICU, where we did vigorous electrolyte replacement. So we were obliged to insert a central venous catheter, and she was put on cardiac monitoring. Later on, the steroid was switched to oral. She was having some fever, and we treated her empirically with vanco and meropenem. We suspected eclampsia, and subsequently the blood culture showed MSSA that was positive also culture from the central line. The kidney biopsy revealed crescentic lupus nephritis 3-5 with DIF full house lupus nephritis. We continued with the furosemide IV. Cardiac MR revealed non-ischemic dilated cardiomyopathy. Blood culture revealed MSSA, and we downgraded her to cefazolin. And later on, after stabilization, the patient received first dose of cyclophosphamide. Now, the patient was later on discharged home. We repeated her cardiac echo that has revealed mild improvement, 35 to 40% ejection fraction. She was maintained on the hydroxychloroquine. We tapered down her steroids, and we tapered also. We were successful in decreasing her anti-heart failure medication, and she was switched to CELSAP. And in her last follow-up, she was on low disease activity. Echo showed improvement. Her proBNP decreased by 60%. And the patient was scheduled for regular follow-up visit in the clinic. Thank you very much for your attention.